Welcome to all of you to this special LinkedIn Live event, Triaging COVID-19, the Ethical Allocation of Life-Sustaining Resources, sponsored by the Markkula Center for Applied Ethics at Santa Clara University. My name is David DeCoss. I'm the Director of Catholic and Religious Ethics at the Markkula Center, and I'm very pleased to be hosting this event today with two colleagues, Dr. Daniel Shin, an infectious disease specialist with the Palo Alto Medical Foundation and at El Camino Hospital, and also with Dr. Margaret McLean, the Director of Bioethics at the Markkula Center at Santa Clara, and a longtime writer and expert on pandemics and ethics. So we join all of you watching today to investigate, in some ways, a particular aspect of this kind of larger pandemic situation we're all finding ourselves in. And that's the questions of how a pandemic can put tremendous pressure on available medical resources and thus affect choices about rationing or about what's called triage, the allocation of care to patients when there may be a crush on such hospital resources. So we've got two terrific experts to help us think through this very challenging problem today. And we welcome very much your audience questions. There's a chat box for live comments. Please submit your questions. And after hearing from Dr. McLean and Dr. Shin, we look forward to getting to your questions a little later in this live event. So for starters, welcome Dr. Shin and Dr. McLean. Great to have you with us to talk about this very difficult but important topic today. And I wonder if we could start, if you could just say a little more about your own experience in the last 3 months or so in responding to this pandemic, and in particular, perhaps how you've had to deal in some ways so far with these triage questions. Dr. Shin, if I could ask if you could begin, please.
So very quickly, we had to scale up preparations for patients coming in. Starting in about February, we had several meetings, and we had to designate containment areas in the hospital, a flow process through the emergency room about where the patients would be isolated, and then which unit they would go to, what type of PPE we would be using, and also which staff would actually be willing to see the patients in these containment units, as we had run through this drill once before for Ebola preparation. So the process was very similar. And then we went over allocation of resources when we had started reading about ventilator shortages and what else we needed to do, which we ended up renting an extra 20 ventilators to support the supply we already had here.
Great, thank you. Dr. McLean.
Well, I've been thinking about this in a couple of ways. One is I am teaching a medical ethics class now at Santa Clara and trying to think of what this means for my students, many of whom are pre-health students, and this changing context and changing way we think about healthcare, and many of them are also seniors. And so they're looking at going out into various professions or medical school or nursing school, et cetera. And so this has really changed the tenor and subject matter of the course. Secondly, I've been working with local hospitals and the Medical Association around adding a new frame to our everyday medical ethical decision making, of pairing our usual frame of thinking about the patient in front of me and what does that patient need with our new pandemic-induced frame of the community around me, and our need when resources are tight to actually shift that frame from the patient in front of me to the community around me, and to prioritize the community, to move from prioritizing patient preferences to protecting the community's health.
Thank you very much, just for both of you, for setting the stage here a bit. And Dr. Shin, if I could go back to you on this. Many people who may not knowingly be infected with COVID-19 or be experiencing those sorts of symptoms may be wondering, what happens to me or to someone I love if I have to go to the hospital with this, in light of what I read about in newspapers about what happened in Italy with very serious and hard triage questions and the like. Could you walk us through what happens to someone when they come into the hospital with these sorts of symptoms?
So the most common route right now is presenting to the emergency room, and they're typically presenting with the signs and symptoms that are consistent with the novel coronavirus or COVID-19. Depending on how ill they appear, their vital signs, their oxygen level, they'll get the test done, but they'll either be sent home and asked to be isolated in their house and wait for the results with a phone call, or if they're sick enough, they have to be admitted, in which case they go to an isolation unit. We've actually instituted a no visitor policy, as have most hospitals. And so what happens is the patient's admitted to the hospital just like they would under any other circumstance, except their family cannot come with them, nor can they visit. And they end up in a certain part of the hospital that's been cordoned off just for this reason, because they end up in an isolation unit in a room that is assigned for that purpose, with a nurse who's only there to take care of that one patient. And the nurse will actually not take care of anyone else except that one person.
Okay, thank you very much. And Dr. McLean, I'm wondering, going back to you, if you might help us all understand a little more general sense. There's always triage in medicine at busy emergency rooms and places like that. What is it about a pandemic that makes this problem significantly, potentially more acute?
I think what's different about a pandemic is the fact that we are potentially facing shortage of resources. So that in the emergency room on a day-to-day basis, yes, there's triage. So when I cut my finger a number of years ago, I waited 6 hours for stitches because there were other people who had much worse conditions than I did who had to see the physician ahead of me. In the case of pandemic, if we get to the point where there is a shortage of resources locally, then the decisions aren't just waiting in line. The decisions become who can be treated, who will be treated. And the fact that some will be treated and there are not enough resources to go all the way around means that others don't just wait. They will not be seen, or they will not get an intervention that they would have gotten, say, in December. I think the other thing that we need to remember about this is that we really, and I do this myself, focus narrowly on COVID-19 infected patients. But there are other patients. You know, there are the heart attacks and the motor vehicle accidents and, you know, other sorts of maladies that patients need to be seen for. And we tend now to kind of just narrow into COVID-19 patients, but the backdrop is that, you know, other people are getting sick. Other people are cutting their fingers. Other people are being injured. And we need to kind of balance then too between those other heart attacks, strokes, etc., and COVID-19 patients.
Dr. Shin, could you tell us at the hospitals at which you work, what are policies now in terms of those other patients, other sick people to which Dr. McLean just referred, people getting heart attacks, injuries? How is that being handled now?
So for the other patients that are being admitted for care, I agree with Dr. McLean. They've kind of not received any attention because of all the media hype.
Yeah.
And at the hospital I work at, the reality is that the majority of the patients in the hospital right now are not COVID-19. There are other hospitals that are reversed, and the majority are, 70, 80% of their inpatient census is COVID-19 patients, depending on where you live, or if you're in New York or even parts of San Jose here, they have a much higher census. But actually, they're making up the minority of the cases we're taking care of. The rest are strokes and heart attacks and accidents and fractures. And I think during the last 2 months, I think the general public has forgotten about those folks, even though we haven't. We're here every day and coming to work, and the majority of the doctors and nurses here are taking care of those patients. And the approach to them is the same. It's just that they're in other parts of the hospital and not not interacting with the other patients in the containment unit.
Well, if we could jump back to the pandemic scenario again here, and maybe drill down a bit more into the ethics and triage issue. So, for instance, I have read people saying the best ethical standard to use in the event of pandemic and triage should be save as many lives as you can. Is that the best standard? What are strengths and weaknesses to that standard? I'm wondering what you both think about that. Dr. McLean, if I could start with you, please.
Sure. Let me begin by restating that standard in terms of saving those who can be saved. And which asks us to recognize that saving some, even if we save as many lives as we can, means that others will perish. And that is, a recognized result of saving those who can be saved. And this is a good first standard, I think. It accounts for medical judgment and preserves scarce resources for those who are most likely to benefit from them. And I think there's a general consensus on saving those who can be saved. Where there continues to be a lot of conversation among my bioethics colleagues, and I think also among those on the front line, is thinking about tiebreakers. In those cases, for example, when two patients could be helped by a ventilator, but there's only one ventilator available. So then how do you decide between patient A on the one hand and patient B on the other hand? There does seem to be consensus that it shouldn't be based solely on age or on disability status. But what is then an ethically defensible tiebreaker? Do we give preference to healthcare workers? Do we give preference to those who keep society humming along? Or do we give preference to those who, for reasons of history or poverty or discrimination, have not had ready access to healthcare? Or maybe a lottery is the most fair, giving all of those all things being equal, all of those who could be saved an equal opportunity to be saved. And those are very active and at times heated conversations.
Dr. Shin, I'm wondering if you could respond to that and how you all are thinking about this at your hospitals. Is save the most lives a workable standard for you, or are you folks working from a different sort of triage guideline?
Currently, we're working from a guideline of save as many people as possible because we haven't run into that situation where a doctor has said or called anyone and said, I have a big problem. I cannot use one ventilator on 2 patients or 3, so I need to make a decision right now. So our approach has been to treat everyone and try to save everyone. But we've had discussions about that if it ever got to that point, especially in this county, if it ever got to that point where those types of decisions had to be made and had to be made in real time, where you can't hold it off till the next week to convene a meeting. It's more or less looking for guidance at the time it's happening.
I'm wondering if you all both could also maybe walk us through. So I've read about concerns on the part of people with disabilities about certain guidelines around the country. And even to the point of I believe some lawsuits have been filed about some of the triage guidelines. So, Dr. McLean, you mentioned disability not being a category of judgment, if I understood you correctly there. Could you help us understand, like, how does that work? You know, why would disability in this particular model, save as many lives as you can, not be used to determine something like who gets care and who doesn't?
When you're looking at that first standard of saving the number of lives that can be saved, you're really looking at medical metrics. And you're not evaluating on the basis of anyone's particular ability to do any particular thing. And so what we want to back away from is making judgments based on someone's ability to do X. And I think the disability community is rightfully concerned that those types of discriminatory judgments will weave their way either explicitly or unconsciously into our decision making around COVID-19. And that's what we want to be able to guard against.
Dr. Shin, in your practice with patients coming in, what do you find that you'd like them to know about triage issues, whether it's COVID-19 or more generally, that you think they generally don't understand? I mean, how would you like to assure them? What don't they understand that would be good for them to understand?
So when they do come in, we tell them that, especially if they're being admitted, they'll receive all the care they'll need while they're here. The other thing we tell them is that there's no proven treatment, even though we will use a type of treatment. There's nothing that's been proven that would actually work for the infection. So most of what we're doing is supportive care. And that despite what they've read, depending on the patient, some of whom we've had here in their 80s, we said, you know, the mortality is higher with age and other medical problems like diabetes, but that won't affect our approach, which will be the same, which will be supportive care to the degree we feel it will benefit you. And they seem to understand that. And they also understand that there's no proven treatment, even though we will start something that we think might work, but we actually don't know. And they also understand that they're going to be in an unusual circumstance, which is sitting in an isolation room by themselves, the nurse is not going to go in there very often or try to minimize the number of visits for reasons of being exposed. So will the physicians. So we try to let them know ahead of time they're going to be alone for a lot of the day, which is kind of the opposite of what we've been trained to do, which is go in and take our time and visit often. Now we're being told, don't go in there if you don't have to. Certainly don't go in there to socialize. And if you need to, call from outside the room or use the iPad. And also bundle all of your care together. So when you make one trip, get everything you need done, and then exit the room instead of going in 4 times separately. So that's been different because it's the opposite of the training we've received. And for the patients who were older or had other comorbid diseases, we have seen some patients who did survive this after 12 days here. So after seeing it for our own eyes, we've convinced ourselves here on the medical staff that we cannot write off people if they're in their mid-80s and have this disease and are getting worse. We actually don't know until we've tried everything, because there are some patients who I didn't think were necessarily going to survive it, and they did. It just took them a little longer, and they actually went home discharged.
Thank you very much. And Dr. McLean, you use the word tiebreakers, and I think most people listening may think of that as applying to an athletic event or what have you.
Yeah.
Could you walk us through again, perhaps maybe in the case of the elderly, as Dr. Shin just referred, how do tiebreakers work in these matters of triage?
So if you have 2 patients or 3 patients or 4 patients and you cannot treat them all, which is not the circumstance, I want to be really clear, that's not the circumstance that we find ourselves in here in the Bay Area at the moment. And hopefully the social distancing and other things that we're doing will mitigate against that and prevent us from being there. But if you get to the point where you have 2, 3, 4 patients who are medically qualified, in other words, they are in a group whose lives can be saved if X happens, but you don't have enough X to give it to all of them, you've already made your first cut, right? You've said these patients can be saved if we do X. But now we have 4 of them, all on equal status. How do we choose among the 4 of them? And that's where the tiebreakers come in. So do you give preference, for example, to healthcare workers? Because after all, they've been on the front line. And one might assume that they wouldn't be here if they hadn't been on the front line. Or do you prioritize our civic leaders who are giving us direction and providing stability, in terms of societal functioning? So it's those kinds of considerations for that group of 4 that are what we're calling right now tiebreakers.
Thank you very much. And we're getting some really important live questions. So I like to jump to those and come back to other questions as we go. But Dr. Shin, a couple of clinical questions here. So I'll pose them both to you. They speak a bit to what you just said a few moments ago. First of all, what clinical criteria do you use for identifying those who can be saved? What metrics? For instance, oxygen levels? And a second question, have there been enough nurses to maintain the 1-to-1 ratio that you have referred to about treatment?
So as of today, we have enough nurses for 1-to-1 ratios. If that were to change, it's going to be because the volume gets too high, and we'll have to have 2 patients per nurse. But through the month of February and March, and now April, we've had enough staff to do 1-to-1. In terms of prognosis and how we look at metrics to decide who is getting sicker or who's very high risk, it's actually the same metrics we use all the time. So we haven't set a new set of criteria for how sick the patient is. It's very much back to basics, which is vital signs, temperature, heart rate, respiratory rate, blood pressure, oxygen level always, and then all the other things we get, which tend to be x-rays, CAT scans, sometimes, not always, and a few labs. The blood labs in themselves have been quasi-useful, not that great. It's mostly been the bedside assessment and seeing the patient physically and looking at their vitals and their chest x-ray, and that actually gives us a good idea when they're admitted how sick they are, and then every day it's repeated. But that process happens to be the same way we do it with stroke, heart attack, hip fractures, everything else. It's actually the same process. It's just gotten heightened awareness because of this disease.
Thank you. And Dr. McLean, a few moments ago, you referred to a possible prioritization in triage of healthcare workers. And that may surprise viewers, listeners, in terms of, well, why should they get priority in such a matter? Could you walk us through some of the arguments right now about that prioritization and, as I understand, a bit of a debate within the bioethics community about that?
Yeah, sure. I mean, I think our first consideration, if one was going to use this as a quote unquote tiebreaker, our first consideration would be, and this again is not without huge amounts of conversation, who counts as a healthcare worker? I mean, there are obvious go-to people, physicians, nurses, but then who else would count as a healthcare worker in terms of prioritization in a tiebreak? So would it be chaplains, social workers, first responders, housekeeping personnel, food service? Just who is in that pool who would count in this sort of tiebreak? And the reasons that people are giving for wanting to prioritize healthcare workers is, one, we need them, right? They are what stands between us and being really, really sick. And so we rely on physicians, nurses, and ancillary personnel when we're hospitalized to take care of us. And if they go down and they go out, who's going to take care of us? Now, people have argued that, well, people are taking 12 days, 14 days, and then they go home and then they still have a recovery period. They won't be back in time to take care of us. I would argue that this coronavirus is not going away anytime soon, and they may, in fact, be back soon enough. So that's the conversation around we need them. Another argument is that from reciprocity. They are putting their talents, their expertise on the line for us. They are supporting us, and they should be given access to scarce resources because they have, first of all, been willing to be out there and care for us, not only now, but in the past and in the future. It's part of what it means to be a healthcare professional, and we should, in some ways, reciprocate for that, say thank you for that by giving them preference. The other, and it's the one that I find probably most persuasive in this context, is that of what we call compensatory justice. That perhaps we owe them a priority in a tie break because we haven't provided them with adequate protection. That we have such a shortage of PPE that it is being, it's actually being rationed in some places, not here. And it hasn't adequately protected people in some cases. And so should there be priority in access to scarce medical resources that we owe them because we haven't provided adequate PPE?
Thank you. And Dr. Shin, if you don't mind, if I may ask a bit of a more personal and kind of vocational question in light of what Dr. McLean has said. You're a physician, you've taken a Hippocratic Oath, and yet you're faced in your work in dealing with patients who are very infectious and putting at risk your own life, the life of those you love. How have you resolved the commitment to the Hippocratic Oath with that possible risk, with the problem also, as Dr. McLean referred to, of often inadequate protection for healthcare workers?
I think on a daily basis, it doesn't cross my mind too often after taking the Hippocratic Oath and then going into residency and then seeing patients now. You're trained to just kind of go do it. When there's inadequate PPE, whether it's a mask or the gown or something is not good enough, you tend to just go with what you have. It's pretty pragmatic. None of us have wanted to put ourselves at risk. And for now, at least, we have enough PPE. But because the supplies are limited, we're actually starting to reuse some things, which we've never done before, ever. We throw everything away in a hospital after a single use. So we are starting to reuse some things and use them more than once. I had never thought about the fact that if a healthcare worker were to get sick in a situation where there are limited resources, that perhaps the healthcare worker would receive preference in those situations for the reasons Dr. McLean pointed out. Because I think the majority of healthcare workers are told this is, the field at least, is not about you. So you should take a back seat to most of what's going on, which is about the patient. Mm-hmm. And also in my own life and in my interactions with nurses and doctors, I try to emphasize that we don't owe you anything. Like, the world doesn't owe you anything. This is your job, right? We're not entitled. And so it's, to me, it's a bizarre thought that we would be given priority over someone else, maybe my own age, who happens to not work in healthcare, and that kind of a lottery process happening. It's very uncomfortable to think about, actually.
Well, I'd like to go to sort of a more of an equipment question. This is one of our questions that have come in over the live feed here. And it pertains to the equipment issue that I think most of us who are not experts have heard most about: ventilators, and a shortage of ventilators, and also the experience of being on a ventilator. So one of our questions is, what's the experience like of being pulled off a ventilator? Does the patient experience the sensation, I'll put it in the tough word, of suffocation? So I'm wondering, Dr. Shin, if you could respond also by setting up for us a little bit, why is a ventilator so important to the care of some COVID-19 patients?
So the ventilator is important because the point at which you need it, you're in respiratory failure. And for a lot of different reasons, you can't breathe by yourself. You're breathing 40, 50 times a minute. You can imagine how tired you get. You cannot keep up that pace. Your oxygen levels are too low. Your diaphragm gets tired, your ribs get tired, and you actually won't last. So if you're at the point you need a ventilator and the ICU doctor thinks you need it, if you don't get one, you will not survive. You'll die. And the actual sensation of having a tube put in your throat and being on a ventilator can feel like a feeling of suffocation. And for that reason, the patients are usually sedated with medications intravenously. And they're also sometimes given pain medicine to deal with the discomfort of the tube in their windpipe. And then they're on the ventilator, in this case with COVID-19, not for a day or two, which we often see with some other illnesses, but actually for a few weeks. And then when they're successfully weaned off and extubated, they're woken up. And if they meet all the clinical criteria to breathe on their own, the tube is, there's a balloon on it that's deflated, and the tube is physically pulled out of your mouth and your throat. And you're monitored, and people are staring at you to see if you can breathe by yourself.
Okay, thank you. Very tough, but it brings the reality of all of this very much home to us. So, Dr. McLean, you've spent many years, and I know this is your longtime colleague, working with hospital ethics committees and on very hard matters. You've spent many years talking with people about ethics in pandemics. Could you speak to us about the phenomenon of what people call sort of moral distress, or the reality of physicians, medical workers facing really hard situations where perhaps ethical guidelines are not sufficient or have not been talked about enough, or where there may be need for counseling for them to deal with the kind of realities they're dealing with?
Well, moral distress among healthcare workers is not unique to COVID-19. You know, moral distress comes from knowing the right thing to do and being unable to do it. So COVID-19 has ratcheted this up with all of these conversations and, in some cases, the reality of these triage decisions, where you know that on any other day, you might have been able to help everyone that has presented in front of you. And today, because you lack a given amount of supplies, you cannot do that. And that creates moral distress, because you know the right thing to do, what you've been trained to do, is to care for all of these patients. And you cannot do that because of the limits of supply. And so that weighs heavily on physicians and nurses particularly, and on nurses very deeply, because they are the ones, you know, you've got a one-on-one relationship or a two-on-one or a three-on-one relationship with your patients as a nurse. And so distress levels, not just because of COVID-19, but on a day-to-day basis, they can face instances of moral distress.
Another aspect, I think, of the moral distress is referred to in another live question here, and I'll direct this to Dr. Shin. But it pertains to what is the conversation among medical professionals regarding allowing family members access to patients in these end-of-life situations? And if I could add to that, what's the conversation around among medical professionals when someone in your profession gets very sick with COVID-19?
So for end of life situations, and we've had the situation happen here where the patients have died from COVID-19, the hospital policy has allowed one visitor for a brief period at the end of life by making arrangements and phone calls ahead of time. And we allow them to be in the room with their family or loved one and spend time with them when we think the end is pretty near and they're going to die. We've done that for every patient who we think was going to die, and family was present. For the healthcare workers, the approach would be about the same if they were hospitalized and were here and got to that point that they were showing signs of a terminal illness. The approach of family and visiting is actually identical. Fortunately, we haven't run into that situation yet with a healthcare worker here being in that kind of extremis situation where they're not going to make it. But the approach is the same.
Thank you. And so we've been talking about triage, and earlier on our call here, our event here, Dr. McLean, you referred to the fact that we haven't thus far in the Bay Area seen the kind of extreme scenarios that I think many of us have read about, say in places like Italy and all. So I'm wondering if you both could speak to sort of social distancing, quarantining, all of these things. How have they had an effect in your judgment in the Bay Area to date in terms of fears that we may have had about these triage situations? I'll ask Dr. McLean if you could speak to that first, please.
Well, I think that the things that we have been doing, the social distancing, now wearing a mask when we're out in public, the sheltering in place, has done what we call flatten the curve. So what it's enabled us to do is to spread possible patients out over a longer period of time. And if you're able to do that, so for example, let's say, on any given day, 100 patients would come to your ER all at once. But if by doing certain measures, you could flatten that out and have one patient a day over 10 days, it would be a better thing. And that's what our interventions here in terms of social distancing and sheltering in place have been able to do. So that has kept us from being forced into putting triage policies in place. Hospitals have worked on those because our primary ethical obligation in the face of pandemic is to be prepared. And so we've been putting a lot of effort into preparation for triage, and all of us hope that we have spent an awful lot of time doing something we're not going to need anytime soon. So stay home.
Dr. Shin, how do you think the practices in the Bay Area, social distancing, sheltering in place, have affected what you all are seeing at your hospitals in terms of patients coming in?
I think it's been effective. Our hospital had its surge in the early part of March, middle of March. And what I've noticed is when the 5-county Bay Area instituted their shelter in place March 18th, first place in the country that did it, actually, based on some preliminary data they obtained from flu swabs the first 2 weeks of March. They just published that data. They found that there was a significant part of the population that already had COVID-19 based on flu swabs that they had collected from 4 urgent cares around the area. and tested those for COVID-19 when the influenza testing was negative. And they detected community spread early in March. And that's what led to those conversations between the 5 county health officers to do this preemptively and do it first. And it was a smart decision.
Mm-hmm.
Now I am noticing, because of that social isolation, sheltering in place, as Dr. McLean stated, if you have a certain number of patients, but you can spread them out over time, it actually buys the hospitals time to get prepared. We can handle the number of patients if they're not all arriving in a span of 2 days. And that kind of mass casualty surge is something most hospitals are not set up for. No one is set up for receiving 80 patients, all with the same disease, all in the emergency room at the same time. No one is set up like that.
In terms of triage and the COVID-19 pandemic, there's been, of course, a lot of concern, if not criticism, of the federal government's role. And some people have raised the question about whether there should be federal triage guidelines that have been developed so that it's not one hospital here, one public health unit over here having to develop these guidelines on the fly. Do you think there should be federal guidelines for triage in the event of pandemic, or do you think the system, as perhaps in ways just happening from place to place to place, is the best way we can do it? Dr. McLean, if you could speak to that first, please.
I actually don't think federal guidelines would be particularly helpful. That's not to say that our fractured healthcare system couldn't use an overhaul, but it is to say that I think state guidance or county guidance is more sensitive to conditions on the ground. You know, California is not Iowa, is not New York, is not West Virginia. And I think state guidelines are more sensitive to the particularities of that geographic region and to what's going on the ground, for example, here in the Bay Area or in California. Currently, public health responses are generated county by county. And as Dr. Shin said, what really helped us here was the 5 Bay Area counties and the city of Berkeley cooperating on guidance and guidelines around social distancing and sheltering in place. And we've also benefited from some clear guidance from Sacramento. So I actually think that countywide or statewide guidance about triage and other responses would be beneficial in terms of both consistency in application of guidelines so that patients would know what to expect no matter where they presented, and also increase transparency. And it would actually take many people who are otherwise on the front lines of healthcare, physicians, nurses, social workers, who have been spending time doing policy development. It would get them back onto the front line if we had guidance that came either from the county health department or the California State Department of Public Health.
Thank you. Dr. Shin, on that question, do you think the way these guidelines are being developed from hospital to hospital, county, state, do we need a federal set of guidelines, or is this system, you think, even in this great crisis, working okay?
I think the situation we have now is working okay. I think general federal guidance would be helpful, and I think national leadership is always helpful. But I agree that the most helpful guidance, especially in public health, tends to be local, and the more local, the better. So the most helpful resources I've found during the last 6 to 7 weeks has actually been our county health department. because the conference calls and the questions are very specific, and they tend to be about what are you exactly doing in your emergency room? Which of these patients can go home to their house? Which of these patients can go to a nursing home? Is the nursing home going to accept them? And also, on these conference calls, we ask about other hospitals locally down the street. We ask about nursing homes specifically, about what's going on in nursing homes. And the response is very specific because they know what's going on. The conference calls I've had at the state level for the whole state of California tend to be more general. And then the conference calls with the CDC, as you can imagine, are very broad. They apply to the United States. They may not even know the name of your county. And it's not, the answers are not going to be specific to where you live. So I have found the local response to be more helpful because it's more specific and it's more practical, actually.
Thank you. We've got another live question here that really speaks, again, in some ways to sort of a sense of vocation and the kind of hard choices that people working in ethics or in medicine have to make now. So if I could pose this question to both of you, and Dr. McLean, I mean, how is it that you sort of work through these hard decisions that you write about in terms of allocation of resources, things like this, where decisions may mean in some ways? Some people could get care, others may not. How have you sort of yourself worked through dealing with these hard questions?
It's not easy. It often requires a box of chocolate, you know, and an ability to, you know, engage and step back, because the policies that we've been working on will, if all does not go well, these policies will affect real people and real lives. And you want to get it right. And that's always the case, you know, with those of us in healthcare. You really want to get it right, because in many cases, and this is one of them, the stakes are so high. So, you know, I find that doing work with people of goodwill, you know, doing things in a collaborative manner, in a bottom up manner, you know, talking to people on, you know, who are caring for patients, who see patients every day, that informs those policies. Just those interactions, you know, can make the stress of developing these policies and thinking about these hard choices easier.
Thank you. And Dr. Shin, I'll read the question really specifically as it came in live. How, as a doctor, do you deal with the idea of choosing care for one patient over another patient?
That kind of decision is kind of mortifying. Choosing one care of a patient over another, I think, depending on what you read about different states, about how they want to handle that question, some of them have taken it out of the doctor's hands and recommended, depending on what state you live in, a third party, being a physician, not taking care of the patient, so they have no emotional ties to the situation, decide for them. Others have wanted a committee to decide, how do you allocate this, remove the decision from the physician, and remove that moral distress of, I can't believe I'm about to decide this by myself. And also the thought of, what if I'm wrong? What if you did allocate it to another person, the person dies with the ventilator, and then you're thinking, wait a minute, maybe that was the wrong choice. The other patient may have done better, but it's too late. So I've never been in this situation before where I've had to think about that kind of decision making about allocation. Neither have most of the physicians on staff here, because we've never had a situation where resource allocation has been so questionable, including ventilators and PPE, about what are we going to do. So I think it's a good conversation, but I really don't know what I would do in that situation, quite frankly. I would probably turn to a colleague right there and say, I'm not sure what to do about this, and talk to another physician who was not involved in the care of that patient.
Well, we certainly recognize the difficulty, to say the least, of those questions and decisions that you're all facing. So we just have a couple of minutes left, literally, and I thought I'd close with inviting you each just to speak, regrettably too briefly, but what, in your judgment, is perhaps the one thing that you would like people listening, people out there in the public, to understand about this pandemic, triage, and ethics that you don't think they understand well enough right now? And I'll start with Dr. McLean.
Well, I think we need to have more public conversations, that we need more transparent decision making, that we need public conversations about what we have learned so far, in terms of the weight of ethics on decision making in a time of pandemic. We need public conversations about our failure to have prepared adequately and how we can prepare for next time. And if you take nothing else away from this conversation, take away that there will be a next time. We will do it better next time, but this is far from over now. And I think it's also sadly a preview of coming attractions.
Thank you. Dr. Shin, what's the one thing that the public ought to know about ethics, pandemics, triage, that you don't think they understand well enough right now?
I think that the conversation about this pandemic regarding those questions needs to continue, because after this is over, people's memories are short. They tend to move on with their lives, and they don't bring up the topic again. And I think it needs to be brought up repeatedly so that there's an answer and a guideline about what to do when this happens again, as she just mentioned, because it is going to happen. And what I've been impressed by are some of the patients who have come to the hospital and been admitted with COVID-19. And before we can even have the conversation about this topic, the patient has told me, let me tell you what I don't want done, because I decided this 3 years ago, and they hand me their advance directives. And it has nothing to do with the pandemic. The patient's prepared. They've had conversations with their family about this issue. And they've said, don't intubate me, don't put me on a ventilator, and don't do CPR, because I've already thought about this for a long time. That kind of conversation and preparation is a great principle to go into with this, because it's something everyone should be doing. And when they present that information to me, the decision has been out of my hands. Now it's in the patient's hands, and they've told me exactly what they want. And I wish out of this pandemic, if more people would have that conversation with themselves and with their family, and then take some action, I think everyone would be better prepared. Even the healthcare workers who I've read about in the newspaper, who are now writing their wills during this pandemic because they have kids. And I thought they probably should have written a will way before this pandemic. If they have dependents, it's probably something all of us should do, but we don't. And so it's all these things that have crossed my mind during this time that make me think we have to keep talking about this, because we'll be having this discussion again pretty soon. Who knows when?
Well, I regret very much that we're out of time. I regret we have many other questions I'd love to get to, but we just don't have the time to do so. But thank you so very much, Dr. Daniel Shin, infectious disease specialist with the Palo Alto Medical Foundation and El Camino Hospitals, and Dr. Margaret McLean, Director of Bioethics at the Markkula Center for Applied Ethics and a longtime scholar of pandemics and ethics. And thank you all for tuning in to this LinkedIn Live event. I'm David DeCoste, Director of Catholic and Religious Ethics at the Markkula Center for Applied Ethics. We look forward to future events sharing important ethical content about the pandemic and other matters in the future. Thank you.
Thank you.
Thank you.